Good afternoon. So, Department of Orthopedics will start with the case-based learning. So, Mohammed can start presenting the case.
Good afternoon, everyone. Myself is Mohammed Burkhan from MPT Orthopedics from School of Physiotherapy, SBV Chennai. Now, I am discussing about my case-based learning session. A case of right femur closed displaced intertrochanteric fracture with subtrochanteric extension, void Griffin type 4. Name Ashok Kumar, age 35, male, from Ortho Department, occupation salesman. He is admitted for the complaints of patient pain over right hip since 4 days and difficulty in moving the right leg and unable to weight bear over the right leg. So the present history of the patient was apparently asymptomatic before 4 days, following which gave an alleged history of skid and fall from bike at near Pallavaram and a sustained injury to right hip and complaints of pain. The patient's initially not able to get up by his own, so they admitted near GH. In there, the radiological investigation was done and diagnosed in a right hip fracture. So they advised for a surgical management, but the patient is not willing. So he came for a SSMCRE for a further management. Here the patient is operated a right femur ORIF with PFN A2 long stainless steel with SS5 fixation on 9/10/2025. So the surgical notes under the aseptic precaution under SA and epidural anesthesia, patient in a supine position on a traction table, parts are painted and draped. The fracture site under C-arm guidance, an incision of 15 centimeter was made along the axis of shaft of femur with the fracture site at the center. The layers deepened and soft tissue exposed, the fracture site visualized. So the fracture is reduced and fixed with the SS wire clutch and using the under a C-arm guidance, the bone owl introduced just medial to the greater organ. A bone owl is just a instrument used for holding, used for the bone to hold, and a guide wire was passed inside the hole, and the serial reaming done with a rigid reamer a size of 9 mm and 10 mm. The 400 into 10 mm size intramedullary nailing with the PFN A2 long stainless steel was passed to the guided wire and fixed. So after fixing the uh, fixing the bone out, the distal locking screw was of size 40 mm and 44 mm was fixed. And then finally thorough wound wash was given and remote drain was put. Suturing is done in layers. Hemostasis achieved. Sterile dynaplast dressing and applied post-op period was uneventful. Hence shifted to post-op ward. The Romo is a drain to use to collect the unwanted fluid accumulation in the surgical site. So this is a surgical notes from an ortho side. Pain assessment. A patient complains the pain of right hip around the surgical site. So the NPRS score is a 6/10 and it's moderate irritability and nature is dull aching around the hip joint. So the patients while doing hip joint movements, the pain is aggravates and they resting the hip joint and on medication the pain subsides. That's a relieving factor. Now, on observation, the patient is built with endomorphic posture is normal, using posture normal, using patient mobility aids using walker and gait is non-weight bearing gait with walker support. Swelling present around the right hip, lower limb over thigh aspect, anterior aspect, and muscle wasting is nil. The attitude of limb of the patient is hip is externally rotated and knee is slightly flexed with 5 to 10 degree with pillow support to avoid fluid accumulation and swelling, and ankle in plantar flexion. So on palpation, the temperature, local rise of temperature in a right lower limb and tenderness are present over the anterior aspect of right thigh. The spasm nil and edema is present, but it's not pitting edema. On examination, the range of motion is passive ROM, hip flexion 0 to 50 degree, hip extension 0 to 10 degree, hip abduction 0 to 10 degree, and hip adduction 0 to 10 degree. The muscle power of the patient is hip flexors, extensor, abductor, adductors are 2 by 5. So mechanism of injury. So the patient intertrochanteric fracture is commonly occur due to indirect trauma such as a fall or road traffic accident where the greater trochanter absorbs the impact. The force is transmitted along the femoral shaft, resulting in a fracture line between greater and lesser trochanter, sometimes extending below the lesser trochanter subtrochanteric region. A subtrochanteric region is nothing but a 5 centimeter below the trochanteric line is called a subtrochanteric region. The fracture displacement occurs due to stronger muscle forces. So the gluteal medius and minimus abduct a proximal fragment, and iliopsoas flex and externally rotates the proximal fragment, and adductor muscles distally medially upward. So these are the muscles while during the injury, this muscle pull the femur from the normal alignment uh, due to trauma. This leads to the shortening and external rotation deformity seen clinically. So in our patients, this classification is for intertrochanteric classification, standard classification used for intertrochanteric fracture. In this classification, there are four types of classes. The first one is simple intertrochanteric fracture. It is a fracture is on the intertrochanteric line without any combination. It's a stable fracture pattern. In type 2 fracture, it is a comminuted fracture which is in posteromedial aspect of the head of the femur. So it is a fracture which is a displaced fracture which moderate instability due to loss of medial support. And type 3 class is a fracture extending distally below the lesser trochanter, and it is with a spiral pattern with the cortical combination. So it is unstable and rotational deformity. And type 4, the fracture line passes from the intertrochanteric region to the subtrochanteric area after oblique and spiral with a cortical combination. It is a highly unstable fracture. So in our patient, it is a type 4. The fracture is on the intertrochanteric region and subtrochanteric area, and it is a displaced fracture. So it is a highly unstable fracture. It is due to some causes due to high energy trauma like a road traffic accident and other high velocity injuries. So femur neck region fracture. It is classified into two types: intracapsular and fracture and extracapsular fracture. The intercapsular fracture is nothing but it is a fracture within the joint capsule, and extracapsular fracture is outside the joint capsule. So the inside the joint capsule, it is divided into three subcategories like subcapital, transcervical, and basicervical. This is nothing but the level of fractures is divided these three categories. And in extracapsular fracture, it is an intratrochanteric fracture and subtrochanteric fracture, and combined with extension, these three types. So in this fracture, uh, intertrochanteric fracture, it is a fracture is in outside the joint capsule. So the intercapsular fracture is a blood supply is affected, and avascular necrosis is commonly seen, and non-union also happens. So it managed by orthoplasty or cancellous screw fixation is done. In extracapsular fracture, the blood supply is preserved. There is a low risk of avascular necrosis, and it is a better healing type. And it is managed by DHS, dynamic hip screw fixation, and proximal femoral nailing fixation, depending upon the fracture stability. So these both types of fracture requires a physiotherapy rehabilitation. So in a trabecular system. So in this case presentation, the trabecular system plays an important role. So I chosen this topic. In this proximal femur has a distant trabecular spongy bone architecture designed to resist the compressive and tensile force during the weight bearing. So this trabecular system is mainly used for role to it it is used to uh, decreases the load to the femur bone to avoid overstrain. There are two main trabecular groups like a primary compressive trabeculae and primary tensile trabeculae, and the secondary trabecular system also have a compressive and tensile trabecular system. So these four trabecular groups helps to make the bone in a cortical continuity and trabecular alignment to maintain the load transfer between the femoral head and the shaft of the femur. So this intersection of the trabecular creates a Watts triangle and naturally a weaker zone with a sparse trabeculae and a common site for intertrochanteric fracture. So in this in between these trabecular groups there is a zone of weakness is there. So this also creates a Watts triangle, which is a very weaker point and also common site for intertrochanteric fracture happens. So pathophysiology of the condition. The pathophysiology is divided into two category, one before surgery and after surgery. So in pathophysiology, before surgery, what are the changes happen inside the body is immediate effects during right after the injury. In a traumatic impact, the direct blow to the greater trochanter, which causes the fracture in the intertrochanteric and extending to subtrochanteric area depend upon the velocity of the injury, and there is a structural damage as to trabecular pattern, and there is a due to the damage to the trabecular pattern leads to loss of cortical continuity and instability of hip joint. So and the muscle reaction at right after injury, there are spasm around the surrounding muscles and increases the pain, and also the restricted the movement due to the pain, and the vascular responses are there is a hematoma formation and the local inflammatory responses like edema, redness, warmth around the uh, injured site, and there is a stimulation of nociceptor which aggravates the pain. And short-term effects after the injury in days to weeks, the local effects persist, swelling, tenderness, and again there is the restriction of movement and pain aggravates day by day functional losses, inability to stand and walk, running and performing aerial activities are non-weight bearing on affected side. So the muscular changes is after the muscle spasm, the muscles are gone for weakness, and there is a stiffness around the joint, and due to the prolonged immobilization and systematic effects is a prolonged bed rest, reduce the cardiovascular endurance, DVT risk, pressure sores, and other complications if we untreated and delayed the surgery. So long-term effects, if not treated properly, like we go for a treatment like conservative management, in that case, the malunion and non-union happens due to the improper alignment of the bone, and there is a deformity, varus deformity also happens, like limb shortening and gait asymmetry also seen in long-term effects due to inappropriate treatment. So the chronic pain and instability, mechanical stress on the hip joint, abnormal loading patterns due to uneven alignment of the hip joint, and altered biomechanics during the weight shifting, weight bearing axis are altered. So there is a functional disability also seen in the patient walking, stair climbing, and other radial activities, which leads to the secondary osteoarthritis. Osteoarthritis of the hip joint due to repeated micro trauma and malalignment, which leads to degenerative in the hip and knee joints. Though psychologically, in overall, that the patient is psychologically affected due to the fear of movement and reduce the confidence and instability during the walking or other aerial activities. So the pathophysiology after surgery. So in this phase, what are the changes happen after the surgery? There is a first phase is inflammatory phase, which starts from 0 to 5 days. In this phase begins immediately after the surgery, and after fracture fixation, the hematoma forms at the fracture and the surgical site due to disrupted blood vessels. The inflammatory cells like interleukin 1 and TNF alpha and PDGF initiate the healing cascade. These are formed to remove the debris and prevent infection from the after surgery. So and prepare the bone for a repairing process. So this after this inflammatory process, next step to reparative phases, which is starts from 1 to 6 weeks. So the fibrocartilaginous callus formation bridges the gaps. So and the osteoblastos derived from the peristonium. The osteoblast cells formed from peristonium and endosteum begin from bone bone. So angiogenesis restore the microcirculation around the fracture. So the new blood vessels are formed to supply the nutrition to the uh, bones after the surgery, and the soft callus is gradually converted to the hard bony callus, providing initial stability. So the fixation with the PNF maintains alignment and allow the proper deposition and proper nutrition to go to the proper nutrition is transferred to the bone, and the callus consolidation is starts. So remodeling phase, there's a third phase. It starts from 6 weeks to 6 months and beyond. The woven bone is replaced by the laminar bone with organized structure. So the in a reparative phase, it's formed by a soft bone, and in remodeling phase, it's gives a texture to the bone, and the osteoclast and osteoblast remodel the callus to restore the normal bone content and increases the density of the bone. The trabecular alignment also normal, depends upon the Wolff's law, and the gradual restoration of bone strength, density, and load bearing capacity also increases. So implant continues to provide support until the cortical continuity is achieved. So after this phase, before the bone is fully growth and fully strengthened, this implant plays a support with uh, the implant plays a support to maintain the stability of the patient. So the mechanical axis are also shifted laterally, increase the bending moment and shear force. The muscle imbalance also seen due to gluteus medius and minimus abduct and externally rotate the proximal fragments. The adductor pulls the distal fragment medially, producing varus deformity. So the already says there is a after the surgery the muscles are weakened, and that is gone for deformity and shortening if the proper physiotherapy treatment is not given for the patients. So the overall, the hip loses its normal force, balance, stability, and energy efficiency during weight bearing and other ideal activities. So the biomechanics of the surgery is a surgical. After surgery, the surgical fixation using a long PNF-A2 aims to restore the normal mechanical axis and load sharing system of the femur. So this femoral nailing is used for act as a load sharing device before the load sharing device before the surgery is fully cured. So restore the compressive tensile balance between the medial and lateral particles. The proximal and distal screw stabilize the fracture to prevent the rotation, allow the controlled impaction, and the adductor lever arm and muscle length tension relationship return to normal, and improves the pelvic control and gait efficiency. The gradual bone healing transfer stress from implant to bone reestablishing the physiological load distribution and functional mobility. So these are the biomechanics after the surgery. Problem identification. It is a ICF format. Its functional limitations. The patient has difficulty in moving right lower limb and weight bearing and walking. An impairment seen are reduced ROM and reduced muscle power due to the muscle weakness, and activity restriction, difficulty in performing daily activities, difficulty in returning to occupational tasks, and a participation restriction, inability to return to working, and reduced confidence or fear of re-injury, and limited participation in a social or outdoor activities. So the clinical reasoning pathway, then the day one assessment, first day of assessment, the pain in 6 by 10 NPRS scale, and ROM, the passive ROM of hip flexion 0 to 50 degree, hip extension 0 to 10, and abduction adduction 0 to 10 degree. So muscle power is hip flexors, extensor, abductor, adductor group is 2 by 5 in a day of assessment. And the problem list is pain, reduced ROM, reduced muscle power. The goal is to reduce the pain, improve muscle power, ROM. So for this problem, we have to introduce the intervention according to the clinical practice guidance of SoPT, physical therapist management of older adults with a hip fracture, and American Academy of Osteopathic Surgery in 2021. According to this clinical practical guidelines, we give the treatment for this patient, and the expected outcome we expected is the pain is 3 by 10, and the ROM is active ROM, hip flexion 0 to 70 degree, extension 15 degree, and abduction adduction is 20 degree, and muscle power is we pushes to muscle power 4 by 5. So the treatment for this patient is a goal setting is short term and long term goal. So short term goal is 1 to 3 weeks. To what are the problem list, we have to improve the outcomes by reducing the post-operative pain and implementation at the surgical site, and prevent the complication such as DVT and other joint stiffness, and maintain the joint mobility in a non-affected limb for yearly mobilization, and improve the circulation and minimize the edema. And begin the gentle hip and knee mobilization in the pain-free limit advised by the surgeon, and maintain the muscle activity using static and isometric exercises, and retain the basic functional activities such as bed mobility and sitting balance. So the long-term goals is for 4 to 12 weeks and beyond to restore the pain-free range of motion with the normal limits of hip joint, and to improve the muscle strength around the hip joint, like abductors, extensors, quadriceps, hamstring to the functional levels, and also the adductor muscle and external rotator also we have to strengthen because it is very weakened, to retrain the weight bearing and gait training. So restore a normal gait pattern, and due to the muscle weakness, the patient is going for a maybe a tender lumbar gait due depend upon the weakness of the muscle. Majorly tender lumbar gait is commonly seen to achieve the functional independence in daily activities, and also promote the correct posture and maintain long-term hip joint mobility to prevent the re-injury, and to give the confidence for the patient. The intervention plan for this patient is phase 1, the immediate post-operative phase. It's between day 1 to 1 week. So the goal in phase 1 is control pain and swelling, prevent pulmonary and circulatory joint complications, maintaining joint mobility, and initiate muscle activation. So intervention, the cryotherapy and limb elevation is given to control the swelling, and deep breathing and spirometry exercises to prevent the pulmonary and complications, ankle pumps and active toe movements and toe curls for DVT prevention. So isometric contraction exercises like for muscles like quadriceps, hamstring, glutes in a 10 into 3 repetitions to maintain the muscle function, and gentle active and assisted ROM exercises starts depend upon the tolerance of the patients, and bed mobility training also start in phase 1, and education to the patient posture and hip precautions, weight bearing restriction in a phase 1 also we have to tell to the patient. And in phase 2, the early mobilization phase and strengthening phase. In this phase, we want to mobilize the patient as much as early, and strengthening the muscle around the joints to goal in this phase. Goal of the phase is restore the joint range and build early strength and endurance, and initiate the ambulance and balance activities. Interventions given in this phase is active assisted and active ROM exercises is given within the comfort of the patient, and the intensity is depend upon the progressive resistive exercises of the patient's tolerance, exercises given for the muscles like quadriceps, glutes, medius, minimus, and hamstring muscles are targeted. Partial and full weight bearing using walker and crutches is encouraged. Gait training emphasizing symmetrical step length, static and dynamic balance drills also starts. The functional re-education from bed to chair transfer, sit to stand activities also encouraged in this phase 2. So the phase 3, the functional recovery phase, it starts from 6 weeks to 12 weeks. The goal in the goal of this phase is active to near ROM and strength, improve the coordination, gait balance, and progressive towards independent mobility. The intervention given in this phase is closed chain strengthening exercise like mini squats, step ups, and wall slides, and progressive resistance weights and bands for abductor and extensor strengthening, proprioceptive and balance training like single leg stands and foam surfaces also starts, and gait progression walker to stick independent like uh, 4.8 to 3.8, like we progress the gait progression, and the stair climbing practices also starts, and low impact endurance work like stationary cycling and pole walking also encouraged in this phase. In phase 4, it is a return to full function phase after the 12 weeks. The goal in this phase is restore the pre-injury strength and activity tolerance, and reinforce the balance and coordination, and ensure the independence in ADL activities and other community mobility. So intervention in this phase is dynamic strengthening exercise like sit steps, hip hikes, and resistance walks, and advanced balance drills in uneven surfaces, uh, single leg with the eyes closed, gait and stair training for normal reciprocal pattern. Yeah, cardiovascular endurance training also starts in this phase, and functional training to return to work, and recreational training also starts. Home exercise and self-management education also given to the patient. Phase 5, the maintenance and long term. Phase 3 to 6 months, the goal is maintain the strength and the mobility and prevent the re-injury and compensate the issues, and also the gain also gives the confidence to the patient in this phase to prevent the re-injury. So in this phase, the interventions is like for most of the patients do the exercise in the hospital setup, and patient is shifted to the home. They can't do the exercises regularly. So the home-based exercise also we tell to the patients to regularly do the exercises, and aerobic activity like a brisk walking and swimming, cycling, and a posture and ergonomic training also tell to the patient. Periodic reassessment for gait and limb length and functional independence. The overall we follow up the patients in physiotherapy department regularly to know the progression of the patients, and intervene and the effectiveness of the intervention we given. So the evidence integration, according to the clinical practice guidelines of AAOS, the management of a hip fracture in older adults. So in this evidence, the yearly operative management within 24 to 48 hours is reduce the complications and the length of stay, and unstable fracture pattern need rigid fixation. So in this evidence, so the after the injury, the patient is operated immediately within 24 to 48 hours, reduces the length of the stay in the hospital, and also improve the functional outcomes of the patient. In meta-analysis and comparing proximal femoral nailing with IM nailing and dynamic hip screw fixation, in this meta-analysis, they tells the unstable intertrochanteric fractures like subtrochanteric extension, the intramedullary lining like PFN and PFNEA shows the advantage and mechanical stability and less varus collapse compared with dynamic hip screw fixation. So in third evidence, the SoPT, the clinical practice guidelines, it is the tells that the structure and the progressive physiotherapy with the early mobilization and progressive strengthening exercises, balance and weight training improves the mobility and functional outcome after the proximal femoral fractures. So the outcome measures of the patients in the POD 4 is a pain NPRS 6/10 and ROM, PROM, hip flexion 0 to 15 degree, extension 0 to 10, abduction 0 to 10 and adduction 10 to 0 degree, and muscle power of the hip muscle groups are 2/5 according to MMT. In POD 4, POD 14, pain NPRS is 4/10. ROM is active ROM, hip flexion 0 to 16 degree, hip extension 0 to 15 degree, and abduction 0 to 15 degree, adduction 15 to 0 degree. So muscle power like flexor, extensor, and abductor, adductor, the hip joints are 3/5. So summary of this case-based learning is the case involves it is a case of unstable intertrochanteric fracture with subtrochanteric extension according to the Boyd-Griffin classification type 4, and it is managed by surgically using the long PNF fixation. After the post-operative, the patient is presented with the pain, complaints of pain, restricted range of motion, and hip muscle weakness, and limited functional mobility. So the pathophysiological changes like loss of cortical continuity and altered in trabecular pattern and other muscle imbalance also seen. So the biomechanical also disturbed due to the normal stress disruption, and liver mechanics also disturbed in this patient. And also overall the phase-wise rehabilitation protocol from SoPT guidelines enable the early mobilization and progressive strength and functional recovery. So in this case, early surgical fixation combined with the timely physiotherapy intervention minimize the complications and enhance the recovery outcomes of the patients. And outcome assessments like demonstrate steady improvement in pain reduction, joint mobility, and muscle performance, also assessed in periodically. And patient education and adherence to home exercise plays an important role to maintain the long-term effects for the patients improvements. These are the reference from the case-based learning. Okay, thank you.
Was nice presentation, Burkhan. But I just want to have point out suggestions so that it will improve the overall quality of the presentation. First foremost, I would is there any past medical history that the patient suffers from, like diabetes mellitus or hypertension? Is there any history of past medical condition what the patient has, which is not presented in the PPT? And then, is there anything?
Yes, sir. Patients has a hyperthyroidism is there, but after the surgery, they know there is a patient has a hyperthyroidism. The diagnosis.
Okay, so I'm not asking about what the finding they did afterwards, but as a past medical history, he's been taking some medication for the past 3 months, 4 years, like that. If there anything, something like that, you could have mentioned it in the presentation. And as the patient is middle-aged men, so pre-injury activity analysis or pre-injury activity level of the patient should be analyzed using some functional outcome. Most of your outcomes are specifically for pain and range of motion and muscle power, but there is a lack for functional outcome scale, like for example, Harris HIP score or LEFS scale, like that. Some scale, if you are added to the assessment, it would be good. And again, in goal setting also, try to make the goal setting using SMART format, specific, measurable, attainable, and time-bounded format. So it will be easy for us to follow it up. It will be easy for us. That's what the suggestions from my side. So try to add some outcome measure for functional status, and to know the pre-injury activity level of the patient, and modify your goal setting according to SMART format. So that's it from my side. But other than that, all the content what you presented were very good and nice.